There's a very important journey I want to take you through today, one that I still am on, I'm learning, and we're all on together. As Keith mentioned, it's a journey where we have to all come together and understand the innovation potential. And I hope that I can demonstrate the power and vital importance of networks in mobilizing change. A journey that should remind us that sometimes the silos that exist around us, the frustrating silos between localities, between vendors, between professional and national organizations, and between ourselves as individuals, may themselves simply be the outward manifestation of the silos we have created in our own minds. And that only by creating a peer set of relationships, which NHS England began with the Code for Health community, are we able to address the interoperability challenge we face. Because as peers, we stand shoulder to shoulder, sharing collective responsibility to listen, to share, and to find common ground. Access to knowledge is one pillar of the principle of do no harm. And for me, interoperability is all about doing no harm. Put another way, it's completely about patient safety. And this became a harsh reality for me in 2009 with patient M, which I'll touch on later. And come 2015, the tech industry came out with the Tech UK Interoperability Charter to improve vendors' role in the sharing agenda. And then the CCIO Newcastle Declaration shortly followed, where clinicians demanded information sharing as a vital part of patient safety and their care and the care delivery they could offer, which I feel has led to the creation of the Interopen movement. So, do no harm is what data sharing is all about. And open standards is fundamental to delivery, as we discussed earlier and some of our previous speakers mentioned. But come on, does information sharing really matter that much? Well, in 2015, 26 billion was put aside to cover negligence claims. How many of these cases refer to communication, sharing information, better access to data, improved openness as recommendations to prevent further adverse incidents? A little bit of that money would go a long way for interoperability. Just a fraction, less than 1%. If we could simply start to record, share, and interpret data with computers, perhaps we could empower patients to look after themselves better as well. An untapped resource that our 30 billion gap needs to tap into today. 30 billion gap. And this requires the sharing of data that is structured, such as medications and problems and allergies, structured to be machine processable. And that requires the use of open standards, so that any vendor, clinician, NHS provider organisation which wants to come in and create an innovative solution can access that data and deliver new models of care, because that's what that means. New models of care means moving data around to do things differently. And so, in 2015, in response to growing pressure from provider organisations who wanted to digitise care better, the Tech UK Interoperability Charter came into existence to encourage the use of open standards to share information. The CCIO declaration came shortly afterwards, a message from clinicians. We declare that in order to provide safe and effective care for all citizens, health and care professionals require unimpeded access to information. So, mid-2015, 2 pieces of paper. What do you do with paper? You store them in a folder. Need to get on with the delivery. Putting commercial interests aside, a group of vendors, a group of people who are passionate, came together and said, let's start a movement. And that is what Interopen is. It's a movement about interoperability and open standards. We've mentioned Professor Wachter today. His paper talks about interoperability about 71 times, I think I counted. So, how many more documents do we need now? Please, let's not do another report. Let's get on with the doing. So Interopen now has at least 60 vendors that have signed up publicly with other people. It has an organizational structure that is growing, it's embryonic, but it is beginning to do things. And it's got a project on. And we'd like you to all be part of that. It's about the delivery of structured data to fulfill the new models of care for the 5-year forward view. And we've got a use case called Michael's journey, Michael's story. We've got a 58-year-old with diabetes, alcoholism, liver disease, and anxiety who is bouncing around the system, who needs transfer of care documents to move, who needs access to information himself because he might want to be part of this journey. We are doing a project using an open standard called FHIR. It's part of HL7, and there are 3 strands that we've started. PRSB is providing the clinical validation of information models. We mentioned FHIR. HL7 is providing technical validation of the standards. We're all working together, and the Interopen community is getting engaged with vendors and individuals who have the ability to contribute and specify what these standards ought to look like from their perspective. We've got these information models on the right that we're starting to do work on. We've already started work on a number of them with PRSB, with HL7, and we will push out that content for wider consultation. An example of a process that we've carried out is we took the international baseline resource, I won't go into detail, of an information model to do with problems. NHS Digital had done some work. Endeavour, which is an organisation in Interopen, had done some work. NHS Digital's work had been influenced by other providers as well. They started to merge these information models, and we hope to provide a set of models which is going to be called Care Connect, the whole care system being connected, that will feed into the GP Connect program, which is actually at the moment sharing unstructured data, but will go into phase 2 to share structured data, and will incorporate these Care Connect profiles. This is real, this is happening, and we need your support.